This presentation supplements the chapter on radiosurgery technique from the 8th edition of Humans and Wind Neurological Surgery. I'm David Schlesinger, and I'll be narrating. The most important principle of stereotactic radiosurgery is one of trying to concentrate dose on the target while sparing surrounding normal tissue from significant radiation dose. Traditionally, radiation oncology uses a small number of broad radiation beams. This is represented on the slide on the left where there's two opposed beams aimed at each other. Tumor tissue and normal tissue are mixed together from the point of view of these two beams, so you're treating across both of them. And so the way traditionally we handle this in radiation oncology is to deliver the complete radiation dose over a large number of small fractions where we give a small dose each treatment session or fraction. And so we let radiobiology do a lot of the work for us. So both normal tissue and tumor tissue accumulate radiation damage, usually in the form of DNA damage. Normal tissue repairs that damage more efficiently than tumor tissue repairs damage. So over time, the tumor accumulates more dose than normal tissue. And you try to arrange the total dose to balance the two damage rates in your favor so that you treat the tumor definitively while the normal tissue has an ability to repair. Radiosurgery tries to turn this concept on its head, so instead of treating both normal tissue and tumor tissue at the same time, radiosurgery tries to only treat the tumor, and it does this by concentrating dose on the tumor so that the dose falls off very quickly, and we can give a really high dose to the tumor in 1 or up to 5 treatment fractions, while the normal tissue basically receives a non-lethal dose over those sessions. This is accomplished in radiosurgery by spreading energy out over a large volume, and this can be in the form of using many different cross-firing beams that are all aimed at a focus point called an isocenter, or it could be in the form of treatment arcs where you move the radiation source in an arc around the patient so that the beams are all aimed at an isocenter. Or it can even be non-isocentric where you don't necessarily aim the beams at a specific point in space, but close to a specific point in space. But either way, you're directing energy from all different directions at the tumor, and that allows the dose to fall off very quickly, and that's what you see on the right side of the slide. The concept of concentrating dose on the target is quite important for radiosurgery because we're often operating under a significant set of constraints. On this slide is a good example. There's a pituitary adenoma. Pituitary adenomas tend to grow in the sella, which is directly inferior to the optic pathways, which are very radiosensitive. And so the goal in this would be to give a really high dose to the pituitary adenoma while largely sparing dose to the optic pathways. And in order to do this, we have to generate a dose gradient that gets you from a high dose to a very low dose in the span of only a few millimeters. And radiosurgery, again, because we can concentrate dose from so many directions on the target, we can generate these sort of dose gradients, and they can be on the order of 10 to 25% dose fall off per millimeter. Now, the ability to do this is fantastic, but it means that radiosurgery has extremely high requirement for accuracy and precision. And so much of the rest of this presentation and much of what is in the chapter deals with the different types of uncertainties and the control of those uncertainties, which is really all about what radiosurgery is. Traditionally, and still today, the way we would control where we're aiming dose at in radiosurgery is through the use of a stereotactic frame, which you can see on this slide on the left. Stereotactic frames serve two purposes. First of all, they immobilize the patient's head mechanically, so there's no motion during the treatment. This is obviously an advantage if you're trying to keep your uncertainties low. A second equally important function of a stereotactic frame is that it creates a targeting coordinate system. So what you see on this slide is an elected G-frame. It defines implicitly something called the Lexell stereotactic coordinate system. if you put an indicator box or a fiducial box, which you see on top of the frame on this slide, and then image the patient with that box, you'll get marks on the image that you see outlined in red. And by registering those marks to the treatment planning system computer, we've put the image itself in the same coordinate space as defined by the stereotactic frame. And then the treatment device, in this case a gamma knife, but there are similar solutions for linear accelerators, also are in the same coordinate system, all relative to the frame. And so in this way, you have a unified targeting system that you can use for accurately localizing and delivering radiosurgery dose. If you use a frame, then usually it's for practical purposes, a same-day workflow. So the way it would work clinically is the patient would arrive for treatment. There would be a head frame fixed to the patient's head, often by a neurosurgeon. The patient with the frame on would then go to imaging, which could be some combination of MR imaging, CT imaging, angiography, different types of imaging that you can image with the stereotactic frame and the indicator box I showed earlier in place. You import those images into a treatment planning system and make a treatment plan. And once the plan is complete and approved, it's exported to the treatment machine. The patient with the frame on their head goes to the treatment machine and is what we call docked to the patient, which is just the process of locking the patient's frame to the treatment machine, so they're mechanically linked. Sometimes there's a collision check that must be accomplished to make sure that through the treatment, as you're moving the patient around the treatment machine, there's no risk of any collision between the patient and the side of the treatment machine. Assuming that passes, then you can confidently deliver treatment where the machine takes care of moving the patient from location to location, but again, the patient's immobilized, so there's very little risk of mistargeting. More recently, a different way of creating stereotactic treatments has emerged that involves using onboard imaging systems that are built as part of the treatment machine. And you can see an example in the top left image of this slide. Modern treatment machines often have cone beam CT systems or other imaging systems that are built as part of the device. There's a calibration between the imaging system and the radiation isocenter of the device. So when you take an image with one of these imaging systems, those resulting images are in a targeting space relative to the machine. And so in this kind of workflow, what happens is the patient is imaged on a simulator or a diagnostic imaging machine. A treatment plan is made. Then the patient on the day of treatment is brought to the machine, imaged using the onboard imaging system. The treatment planning images that show the patient's position on the treatment plan and the image from the treatment machine that shows the patient's position currently are co-registered and compared. The difference in those two positions is calculated. The patient is shifted in position to correct for the difference in position, re-imaged, and once everything is correctly aligned, then you know the patient's in the correct position and you can treat. And so the advantage of this kind of system is that instead of using a relatively invasive fixed stereotactic frame, you can treat with less invasive immobilization systems such as thermoplastic mask systems, which we'll talk about a little more later. The workflow using this kind of frameless system proceeds kind of in two steps. There's a pre-treatment preparation step where a thermoplastic mask is created for the patient. Thermoplastic masks are a type of plastic that becomes soft when they're heated. So they're heated to a warm temperature, usually around 165 degrees, and they can be molded to the head of the patient. And then as it cools, it becomes rigid, and it does a reasonable job of immobilizing the patient. Then an image is taken of the patient in treatment position using the onboard imaging system of the treatment machine. You fuse in any kind of simulation image or prior diagnostic image to that the image that you take on the treatment machine. And once you have all this, you can make a treatment plan. You might also do a dry run of the patient in the treatment position to make sure that there's no collisions between the patient and the treatment machine. Then on the day of each treatment, the patient is brought to the machine. Image using the onboard imaging system of the treatment machine is performed to determine the patient's current position that day. Those images are co-registered to the reference image that was taken during the pre-treatment preparation. The required positional shifts are calculated, the patient shifted into the right position, the imaging is repeated, and once everything is correctly aligned, treatment delivery can proceed. And then that treatment day step is repeated over each day of treatment. Both the frame and the frameless methods of radiosurgery require a treatment plan, and there's two basic methods for treatment planning. There's what's called forward planning and a different method called inverse planning. In forward planning, the person doing the treatment planning manually decides on the placement and the relative importance of each beam, or in the case of gamma knife radiosurgery, each isocenter to the treatment plan. And the treatment planning process is a very iterative process where a beam is placed and maybe moved around, and the weight relative to all the other beams is changed manually, all by the treatment planner. And the treatment planner might be a dosimetrist, a medical physicist, a radiation oncologist, or a neurosurgeon. Inverse planning, instead of placing all of those things and reweighting them and moving them around manually, what happens is the person doing the treatment planning decides on something called plan constraints. And these are usually dose versus volume constraints. So for instance, 95% of the tumor must have greater than 95% of the prescription dose, or alternatively, some small percentage, like no more than 10% of some critical normal tissue structure should receive more than 50% of the prescription dose, or something similar to that. And again, it's an iterative process, but the process isn't so much moving things around as it is adjusting treatment planning constraints. Now, there are some pros and cons of each method. The forward planning method can be faster if you're very good at it. However, it depends a lot on the skill of the person doing the treatment planning. The inverse planning method is very useful when you're using techniques such as intensity modulated radiation therapy to deliver the beam treatment, and you have a lot of multi-leaf collimator leaves on a linear accelerator moving, and the number of degrees of freedom gets to be too much to manage manually, so it's helpful to have an optimized computer algorithm to come up with a solution. Now, once you have a treatment plan, another important concept for radiosurgery is to be able to measure how well the treatment plan did. And there are a few different metrics that are commonly used in radiosurgery that are worth mentioning. The first one is called the conformity index. A conformity index is just a metric that tries to quantitatively describe how well a treatment plan matches the target. So if you look on the figure on this slide, you can see a tumor that's basically brown. The tumor has a volume, which is labeled TV on this slide. There's a reference isodose, which is the prescription isodose or prescription dose level line that ideally perfectly matches the boundary of the target, because radiosurgery theory says that you want to be able to give at least a minimum effective dose to the tumor that kind of straddles the boundary between what we're going to call effective for harming the tumor and not effective for harming normal tissue. So you want to put that reference isodose as closely conformal to the surface of the tumor as you can. And so you can then calculate a few indices. So one conformity index is the RTOG conformity index, which is defined as the volume of that reference isodose divided by the tumor volume, where if you get a conformity index of 1, that's perfect conformity, but there's no penalty really for missing the target. It just depends on their relative volumes. And then there's more commonly used in the radiosurgery world something called the Paddock Conformity Index, which has two different terms. One is an undertreatment term and one is an overtreatment term, so you're penalized both ways. It's defined as the volume of the tumor covered by the reference isodose divided by the total tumor volume. So that's basically the percentage of the tumor volume covered by the reference isodose. And then there's the tumor volume covered by the reference isodose divided by the total volume of the reference isodose. And that is basically an overtreatment penalty term. So if you treat too much normal tissue, you're penalized. And so that index has a range between 0 and 1, where 1 is perfect conformity. Another thing that's important to look at besides conformity is how quickly the treatment dose falls off outside the tumor. And for that, we use an index called the gradient index. The gradient index is defined as the volume of the isodose that's 1/2 of the reference isodose divided by the volume of the reference isodose. So if, for example, your prescription isodose is, or your reference isodose is at the 50% isodose line, then the numerator would be the volume of the 25% isodose line divided by the volume of the 50% isodose line. If instead the reference isodose is the 60% isodose line, then it would be the volume of the 30% divided by the volume of the 60% isodose line. And this again was invented by Paddock et al. And in the paper that defined this, through experience, they defined a gradient index of less than 3 as something to kind of aim at in terms of gradient index. If we try to put the conformity index and the gradient index together, this slide kind of explains what can happen. So these are two different treatment plans. They have the same conformity index. They were both planned to the 50% isodose line, which you see in yellow. So the volume of the 50% isodose line is the same in both cases. They're covering the same amount of tumor in both cases. But the volume of the 25% isodose line is very different between the two. On the left-hand side, it's 4.7 cc's versus 5.4 cc's on the right. And because of this, the gradient indices are very different. So on the left, it's 2.76, and on the right, it's 3.18. And you can see why by looking at the figure. You can see that in the right-hand side of the figure, near where the tumor is kind of pointy laterally, you can see that there's a much less sharp dose fall off, so you're treating more normal tissue. And so that's something that you want to avoid in radiosurgery, and the gradient index helps you get to that information. Finally, another really important concept in radiosurgery is to understand procedural uncertainty. So we already talked about how the high doses and close by radiosensitive anatomy means that your uncertainty is really paramount when you're thinking of doing a radiosurgery case. But radiosurgery is a pretty complicated multi-part procedure, and every step has its own set of uncertainties, and that includes everything from the mechanics of the beam delivery devices to how well the dosimetry was calibrated, to your ability to position the patient accurately and precisely with the treatment machine, to how well you're doing your dose calculation, to your understanding of the radiobiology of the situation, to your imaging. All of this plays a role in radiosurgery. So I think the message I'd like to leave you with is that as you're learning about radiosurgery technique, it's really important to understand where the risk and the uncertainties in each of these steps are, and try to minimize them as best you can to have optimal results. Thank you.